I'll taking practice question 6 of the May 2023 exam. Where's my slide? Okay, and the question says 36-year-old lady with symptoms of abdominal swelling, leg swelling, autopnea and cough, productive of brownish sputum. On examination, she has an irregular pulse, raised JVP, pansystolic murmur, loudest at the apex and radiating to the left axilla, and bisal coarse crepitations. History of sore throat infection in childhood. A, what is your diagnosis? B, what investigations will you do? C, how will you manage? D, what are the prognostic factors? So what is your diagnosis? My diagnosis is congestive cardiac failure, secondary to rheumatic valvular heart disease, precipitated by atrial fibrillation and chest infection. Patient had a history of abdominal swelling, cough, autopnea, and she had features that met with the primary criteria of heart failure and also atrial fibrillation. It was stated that she had an irregular pulse, even though we're not giving the heart rate and the pulse rate. And also she had cough that was productive of brownish sputum. What investigations will you do? I'd like to do a chest radiograph for her, which will show cardiomegaly and features of pulmonary congestion. It will show us alveolar edema. It will show us cardiomegaly. It will also show us Kelly B line and other features of heart failure in the chest, and also for the fact that she had production of sputum. It's possible that she has a chest infection, which should also show us a consolidation. And I'll do an electrocardiogram. Already stated that she has an irregular pulse, so there might be absent of the P wave and irregular reading. I'll do an echocardiogram for her. Electrocardiogram and echocardiogram, which will give us, it will quantitate the severity of her mitral insufficiency and also pansystolic jet length equal to or greater than 2 centimeters with a peak velocity equal to or greater than 3 seconds in 2 sections. In at least 2 views, and also the echo will help to assess the left ventricular function and if there's any intracardiac thrombus. Echo will also show us chamber dilation, annular dilatation, caudal elongation, anterior leaflet tip prolapse, beading and nodularity of the leaflet tips. Other investigations that will be done will be a serum anti-streptolysin, ASO and or anti-DNase B antibody titer. 2 blood samples will be taken 2 weeks apart, and typically 3 to 6 weeks after pharyngitis. I would like to do a full blood count, which will show leukocytosis. As sputum MCS may detect the pathogen, and it will guide us on the antibiotics we will use for management. Erythrocyte sedimented rate will also be increased in this patient. Our C-reactive protein will be normal or elevated. Cardiac markers, the BNP and the NTB pro-BNP may be elevated in her because our patient has heart failure. And we also want to exclude other myocardial damage by doing a cardiac troponin. Other investigations, ancillary investigations that will be done will be our electrolyte creatinine, will give us an electrolyte imbalance, and also help us to assess our renal status. We'll do our PT and INR for baseline monitoring of our patient. How will you manage the patient? My principles of management will be for first of all, I'm going to do a supportive management, then also specific management. For my supportive management, I would like to admit my patient, place on bed rest in cardiac position. I would like to restrict our sodium to 2 grams per day, and also fluid restriction to avoid and to help with the fluid overload. Then my specific management will be for secondary antibiotic prophylaxis, where I'll be giving her intramuscular benzathine penicillin G every 4 weeks. Then I'll manage a heart failure by using diuretics and other drugs that will help with the regression and the resolving of the heart failure. I'd like to manage our atrial fibrillation pharmacologically with beta blockers or our non-dihydropyridine calcium channel blockers, and also amiodarone for cardioversion. Our patient has atrial fibrillation and she's also in heart failure, so she'll benefit from catheter ablation. I would like to anticoagulate my patient to prevent stroke and I'll be using the oral vitamin K antagonist or the factor 10A inhibitors. And I would like to treat coexisting infection. Patient presented with sore throat 2 weeks prior, and also patient is coughing and has production of sputum, so should benefit from macrolides for atypical pneumonia. And also this will serve as a baseline treatment for her before her sputum MCS is out, which should guide us on our antibiotics management. Then surgery, depending on the extent of severity of the mitral insufficiency, should benefit from a mitral valve repair. What are the prognostic factors? The female gender, younger age, degree of cardiac valvular damage, and cardiac involvement with left ventricular dysfunction, and recurrent acute rheumatic fever attack in the future. So I'm going to talk briefly, take an overview of rheumatic heart disease. Following this outline, introduction, diagnosis up to my references. So introduction, rheumatic heart disease is a systemic immune condition that occurs as a complication of rheumatic fever. It remains a major cause of cardiovascular disease in resource-poor setting, and it was common in all countries until the early 20th century, when incidence began to decline in industrialized nations due to the use of antibiotics and also the new antibiotics that were found to help with the management. The introduction of antibiotics and improved system of Medicare have all contributed to this decline. Epidemiology, rheumatic heart disease accounts for approximately 50% of all patients with heart failure in endemic countries, and the prevalence of rheumatic heart disease has been rising steadily since 1990, reaching 40.5 million currently affected in 2019, with the highest prevalence, disability, and mortality in Oceania, South Asian, and Sub-Saharan Africa. It's a disease affecting predominantly those living with poverty, inadequate access to healthcare, and unchecked exposure to group A streptococcus. The prevalence ranged from 3.4 cases per 100,000 population in non-endemic countries to greater than 1,000 cases per 100,000 in endemic countries. There are few reports of sporadic outbreaks of acute rheumatic fever in the United States in the 1980s and 1990s, and more recent reports from Australia and Italy. Studies done in Kano in Nigeria showed using a total of 1,499 echocardiographic examinations that were done in 2 centers over a period of 4 years. 129 of the 1,312 patients, that's 9.8%, with abnormal results, had an echocardiograph diagnosis of rheumatic heart disease, and there were about 47 males and 82 females in a ratio of 1:1.7, and their ages ranged from 5 to 60, with a mean age of 24.0 to plus or minus 12.75 years. Mitral regurgitation was the commonest echocardiographic diagnosis present in 49 patients. 10 had mitral stenosis and 4 had pure aortic regurgitation. Complications of rheumatic heart disease observed included secondary pulmonary hypertension in 103 patients, valvular cardiomyopathy in 41, and functional was seen in 39 of the patients. Now, the natural history of rheumatic heart disease: acute rheumatic fever, clinical or subclinical, it usually causes pancreatitis, where we have pericarditis, myocarditis, and valvulitis when it affects the endocardium and the valves. Over the years, there has been a transition from rheumatic carditis to rheumatic heart disease. Progressive valvular disease commonly occurs in the first year, in the years after 1 or more episodes, and ARF recurrence is highest with an incidence of 3.7 per 100 person years in the first year after the initial ARF episode, but low level risk persisted for over 10 years. Progression to rheumatic heart disease was also highest in the first year, almost 10 times higher than acute rheumatic fever recurrence. A prospective study of children with ARF followed up to 2 to 15 years in Brazil found out that 72 of the 258 subjects developed chronic valvular disease, and 60% progressed to severe aortic or mitral disease. Although chronic rheumatic heart disease occurs.
Hello, doctor.
Yes, sir.
I think you should just go because it's almost 10 minutes already. Why don't you just go straight to the meat of the matter, like the pathophysiology and management, okay?
Our clinical features.
Thank you, Chief. You have one more minute.
Yes, you can. Thank you. You can present with rheumatic carditis, pericarditis, or valvulitis. We have isolated aortic disease can also occur in 2% of cases, and the right-sided valve involvement is rare. Now we have, they can present with lesions such as the mitral annular dilatation, chordae elongation, chordae rupture, and features of heart failure where they have dyspnea or topnea, PND, bilateral leg swelling, and cough. The diagnosis will first of all take a history for our patient, examine our patient with signs and symptoms of heart failure, and common triggers are pregnancy, acute heart failure, atrial fibrillation, embolic events, and infective endocarditis. Also, we'll do an ECG for the patient, chest X-ray that will give us our different findings, and also our echocardiogram. Okay, for our management of rheumatic heart disease, we have a registry-based care that is recommended by the WHO as a vital adjunct for the prevention and control of rheumatic heart disease. And primary care providers are to participate in the maintenance of rheumatic heart disease registries. For secondary penicillin prophylaxis, which is our specific management, and it started with those with an initial episode of acute rheumatic fever at high risk of recurrence. Treatment of symptomatic streptococcal infection is not adequate to prevent acute rheumatic fever because asymptomatic JS can trigger acute rheumatic fever. So for our management, we start with our intramuscular benzathine penicillin, and the current AHA guidelines recommends BPG as preferred agent for secondary prophylaxis as follows. Our Schedule 1 is intramuscular benzathine penicillin every 4 weeks for most patients, or Schedule 2 of intramuscular benzathine penicillin every 3 weeks for those at high risk or those who experience recurrent episodes of acute rheumatic fever. Despite high adherence to every 4 week schedule, will benefit from the Schedule 2. Now, it's noted that the benzathine penicillin G is said to be superior to oral penicillin in preventing the pharyngitis and recurrence. Then other options, our medical options, is for those that cannot access surgery, and agents such as diuretics are used. ACE inhibitors are used, and beta blockers and digoxin are used for those that present with atrial fibrillation. The management of CCF for our mitral stenosis, diuretic for preload reduction, beta blockers allow greater diastolic filling, and catheter or surgical intervention is the proven effective management. For aortic regurgitation, ACE inhibitors, ARB, beta blockers have shown beneficial effects. Diuretics and beta blockade may be complementary in multi-valve disease, and for our mixed mitral valve disease, we usually do benefit from surgery. For AF is a common complication, and its frequency is usually found as follows. For the management, we have features that are associated with it: age, LA size and strain, LA pressure, and complications of AF include heart failure, stroke, thromboembolism, and premature deaths. For the treatment of AF, we have the pharmacological treatment where non-dihydropyridine, CCP or beta blockers are used. Then amiodarone is also used for the patients. Then catheter ablation will be beneficial for those that have AF and also heart failure. Then we'll anticoagulate for stroke prevention using our CHAS-VAX score and also our bled score to assess our patients. For endocarditis, it usually occurs from poor oral hygiene, but usually common in them. Okay, I'm almost done. Then for our pregnant women, we usually advise them to prevent pregnancy because pregnancy worsens the effect of the rheumatic heart disease and can lead to death. So they usually advised to use, we have pre-conception counseling where they use oral contraception. Then women with mechanical valve replacement will require anticoagulation throughout pregnancy with low molecular weight heparin first, then they are switched to warfarin. In conclusion, the burden of rheumatic heart disease is still a major public health concern, especially in low and middle income countries. And medical treatment provides limited symptomatic relief, but advanced rheumatic heart disease and its complications can be addressed by interventions. Thank you.
Oh, thank you so much, Dr. Makri, for that beautiful presentation. So now we'll take comments and questions from the participants first, and let's keep the things coming on the chat. Okay, Chief, please, can you go back to the question so that maybe we're making our comments from there?
Okay.
Then, as an add-on, I just wanted to suggest, before giving the prophylaxis for the chest infection, that the prophylactic penicillin, I think to the treatment for the chest infection, it would be good to add a cephalosporin or penicillin for 5 or 7 days to treat the chest infection first, because you give only a macrolide. I think it's because for community-acquired pneumonia, you're supposed to use a macrolide and a cephalosporin or penicillin. And then I was just thinking aloud, is it possible that the atrial fibrillation is a complication of the rheumatic heart disease, as the mitral regurgitation, instead of a precipitant? Because I think
for this patient.
Yes, for this particular patient, because I think they said she had the sore throat in childhood. So is it possible that she had the disease and it's just, how old is she? Okay, just go to the question.
She's 36 years.
Okay, is it possible she had the rheumatic heart disease long before it's manifesting? Because in rheumatic heart disease, where with mitral regurgitation, the symptoms could manifest years after the disease onset. So I was just thinking aloud. Thank you so much.
Okay, this patient is young. Initially, they usually there's an acute infection that might resolve. They might not have any symptom. Maybe they'll have a post-streptococcal infection and that will affect the kidneys at that acute onset. But when it progresses further, they have repeat infections or there's damage to the cardiac valves or the muscles. That's when it to continue on to the chronic parts. So we have the chronic part where they now have the carditis and finally the rheumatic heart disease. So it's actually the rheumatic heart disease is actually a chronic manifestation of an acute that has occurred years ago.
All right, thank you so much. Okay, so let me just, I'll skip the thanks, a lot of thanks to you on the chat, but let me just go straight to the questions before Dr. Kalamawa comes in. Okay, Eda is saying thank you. Please, why are we doing sputum MCS? And what's the reason for penicillin therapy?
Okay, penicillin, we are doing sputum MCS because our patient, apart from the fact that she presented with a sore throat years ago, she also has a sputum that is productive of brownish sputum. So the MCS will guide us on the specific antibiotic to use in our management. Then the penicillin therapy is used for prophylaxis, not for management. She has had this rheumatic valvular disease. She has had this the post-streptococcal infection long ago. So she's history of sore throat infection in childhood. But right now she's presenting with valvular complication. And penicillin therapy is usually used for prophylaxis, not for management.
All right, thank you so much. So a lot of thanks. First, thank you for a lovely presentation. What are the options for prophylaxis in patients with penicillin allergy?
For prophylaxis in penicillin allergy, I searched, I just saw reduction of the penicillin, but you can use I'm not specific, but I think you can use a broad spectrum antibiotic or other, you can use a ciprofloxacin in place of the penicillin therapy if patient is allergic to it. Well, I stand to be correct.
Thank you. Okay, so a lot of other thanks. And then Dr. Ademo says, thank you for the wonderful presentation. Will the patient benefit from a thyroid function test before amiodarone?
Yes, patient will benefit from a thyroid function test because amiodarone is known to destroy the follicles of the thyroid and can cause in future hyperthyroidism for the patient.
All right, thank you so much. A lot more thanks. And then Dr. Wasinda says, thank you, Dr. Ibinabo, for the presentation. Can we also add the type of murmur she had in the diagnosis?
Yes, please, that will be added. If she had a pansystolic murmur, I'll do that. Thank you, Dr. Basinga.
Okay, sorry, is it that you say with pansystolic murmur or you say with mitral regurgitation? I just wanted to be clear
Okay,
on that.
congestive cardiac failure, secondary to rheumatic valvular heart disease. Well, the rheumatic valvular heart disease is also stating that there's also a valvular issue, which will include the murmur, preceded by atrial fibrillation and chest infection with a pansystolic murmur.
Okay, thank you. So Dr. Shamsuddin is asking, at what age will you stop the prophylaxis?
For the prophylaxis, it stated that for a patient that is patient can take it up to 10 years. Okay, the American Heart Association says for the prophylactic antibiotics should be given for 5 years or up until 21 years. Now, for patients with rheumatic fever and carditis, but they don't have any valvular disease, they should receive prophylactic antibiotics for 10 years or well into adulthood. Then also for patients with rheumatic fever with carditis, like our patient had, and valvular disease, should receive antibiotics for at least 10 years or up until their age 40. So our patient is already 36 years. So she will receive it till she's 40 years.
All right, thank you so much. And then Dr. Blessing Amadi is saying, is BNP or NT-proBNP not always elevated in heart failure? You mentioned that it may be elevated.
Yes, it's elevated in heart failure.
All right, thank you so much. Okay, Dr. Kalamawa, please go ahead.
Okay, thank you so much, Dr. Ebinabu, for that excellent attempt. I just have add-ons to make. I can remember in my part one, I actually met a patient who had, my cardiologist patient was a patient with rheumatic valvular heart disease. And a question was asked by me, by the examiner, how would you differentiate rheumatic valvular heart disease from a DCM? I think that was the question somebody was asking, that would you put the aspect of the murmur? Okay, so basically, in rheumatic and valvular heart disease, we have apical pansystolic murmur that is radiating. So, but for DCM, that's dilated cardiomyopathy, we also have that apical pansystolic murmur, but non-radiating. So that's what actually differentiates rheumatic valvular disease from a DCM. Like now, if you look at this patient, they mentioned that patient had apical pansystolic murmur that is radiating. So that clenched it to the patient having a mitral regurgitation, it was at the apex. Okay, then secondly, doing an echocardiography, it can also help us to stage what stage of heart failure this patient is in, whether this patient is having heart failure, maybe reduced ejection fraction, with reduced ejection fraction, or with preserved ejection fraction. So that's like an add-on to one of the reasons why we have to do echocardiography. Now, we're managing a patient with AF. AF is actually based on the duration of the AF, like managing a patient with AF, the duration of the AF, and also this patient is hemodynamically stable. Then now, for example, this patient, I think this patient was hemodynamically stable, and then but they didn't give us the duration of the AF. So if the AF is actually less than 45 hours and this patient is hemodynamically stable, basically what we'll do is that we will just anticoagulate this. We would give an antiarrhythmic for this patient, giving like we'll do a chemical, we'll do a chemical cardioversion where we'll give amiodarone or flecainide. Like how this patient already had a valvular heart disease. So this patient will benefit from amiodarone. So that's what this patient will benefit from, because this patient already has a structural defect and probably this patient is hemodynamically stable. So amiodarone is what this patient will benefit from. Now, if this patient's AF is actually less than 48 hours and the patient is hemodynamically stable, we will just electrocardiovert this patient if it is less than 48 hours. Then, secondly, if this AF is more than 48 hours, this patient is at risk of thrombus formation. So basically, what we'll do is that if this patient's AF is more than 48 hours and the patient is hemodynamically unstable, we will have to do a transesophageal echocardiography to rule out a thrombus that can be found in the left atrial appendage. So basically, what we do is that, but here we don't really have the transechocardiography machine. So what we do here is that we will just give this patient an anticoagulant for like 3 weeks before we now electrically cardiovert this patient and then maintain this patient on an anticoagulant for another 4 weeks. Why we are doing this is to rule out that this patient doesn't have a thrombus. so that when you electrocardiograph this patient, the thrombus is not released, and then what happens is that you can have a PE or a thrombus is being dislodged. Secondly, if this patient's AF is actually more than so that's what I have to say about that. Then secondly, for the young people, we actually go with rhythm control, and then the elderly people, we go with rate control. So for the elderly people, if the patient is not in acute heart failure, the patient will benefit from a beta blocker for the rate control. As regards when the patient is in acute heart failure, the patient will benefit from digoxin. So that's just like an add-on I have to make for this particular case. Thank you.
Thank you so much, Mama. Dr. Semitope, please go ahead.
Good morning, teachers and everyone. Thank you once again for the presentation. Okay, so I think somebody responded on the group regarding the alternative medications for patients with penicillin allergy. So either macrolide, and the preferable one is azithromycin, clindamycin, or sulfadiazine. So those are the 3 classes of drugs that can be used in patients with penicillin allergy, and it's important that it's actually confirmed penicillin allergy. So it has to be, we have to be sure it's penicillin allergy. Then for the duration of prophylaxis, like I think somebody asked for this patient and he said 40. So it's actually the longer option that is best to choose. So for like this patient that has rheumatic fever with carditis and residual heart disease, it's like you said, for 10 years or up to 40, whichever is longer. So for this patient, it would be the 10 years. So that would be 36 plus 10. So probably till she's 46. Then nowadays, some cardiologists also talk about the role of lifelong prophylaxis, but I think I'll leave that for our cardiology teachers in the house. Thank you.
Thank you.
Well, thank you so much, Dr. Temi. Okay, let me just take a few more comments then. Our teachers will come in. I can't see any other hands. Okay, so Dr. Ida is asking, the brownish sputum, can it be explained by acute pulmonary edema? I think it will be more of infection. Then Dr. Temi is adding, can the diagnosis be CCF secondary to rheumatic valvular heart disease, predominantly mitral regurgitation, preceded by AF and then sepsis-focused chest? Okay, thank you, Dr. Temi. Dr. Mamodu is asking, amiodarone can cause either hypo or hyperthyroidism with Wolff-Chaikoff or Jod-Basedow effect, respectively. Okay, thank you so much, Dr. Mamodu. Dr. Jamila says, thank you for the presentation. The prophylaxis is for 5 years or when the patient reaches age 21, whichever comes last. Okay, Dr. Oladeko added the drugs for the alternative medications, oral clindamycin, oral azithromycin, oral clarithromycin, and then Dr. Temi is also adding, kindly note, all rheumatic mitral valve disease radiates to the axilla. Okay, not all rheumatic mitral valve disease radiates to the axilla. It depends on the valvular affectation. For anterior mitral valve affectation, it classically radiates to the axilla. For the posterior mitral valve, it radiates to the left sternal border. All this depends on the severity. Thank you so much for your comments, participants. Okay, I can't see any other electronic hands up. Okay, so I think I'll hand over to our teachers at this point. Mark Christabel.
Yes, thank you. I think there's a comment from Temitope.
Okay, let me just take it.
Yes.
Okay.
Thank.
Okay, so from Dr. Mosope Orogun, well done for the presentation. Ciprofloxacin, mentioned by the presenter, has limited action against GAHBS. Other fluoroquinolones, especially the respiratory fluoroquinolones like moxifloxacin and levoflox, are preferred. In fluoroquinolones must be used, but are usually costlier. But the preferred alternative are those earlier mentioned, that's the azithromycin and clindamycin. Then Temitope says penicillin allergy, you use the macrolide, azithromycin, clindamycin, and sulfadiazine. Okay, thank you so much, Dr. Temi. Okay, and then Dr. Olalekan says, I think the diagnosis may have been stated as congestive heart failure, secondary to rheumatic valvular heart disease. bracket mitral regurgitation precipitated by arrhythmia and chest infection. AF is not the only cause of irregular pulse. Then there are no features of sepsis. Thank you. Thank you so much, Dr. Lalekon. Okay, ma'am.
Okay, thank you. Thank you to our presenter, Dr. Ibinabo. That was quite lucid. Excellent. Thank you so much. The commenters, Dr. Kalamama, Dr. Olalekon, Dr. Mosokwe, Dr. Mamodu, and others. Thank you so much. Thank you. Dr. Kopi, Dr. Fatima, don't know if you guys have any comments? Dr. Remigo, okay.
Yeah.
Go ahead, please.
Okay, this is a really excellent discussion. There is an active participation from all the class members. And I think for general medicine, with regards to this question, diagnosis, if you see congestive cardiac failure, secondary to rheumatic valvular heart disease, precipitated by arrhythmia and chest infection is okay, since there is bibasal cause crepitations, death is likely to be chest infection. If it were a fine crepitation, then it is just from pulmonary edema. Investigations are quite in line. Then management, you look at management of heart failure, then management of the arrhythmia, management of the underlying infection, then prophylaxis, as the group has mentioned. Then the prognostic factors were also mentioned, the severity of the heart failure, presence of infection is also a proper prognostic factor, presence of arrhythmia, as well as severe LV disease. For instance, patient coming with very low ejection fraction and all that. By and large, it's an excellent discussion. The cardiologists have contributed well. Thank you.
Oh, thank you so much. Thank you so much, Dr. Fatima.
Hello, Dr. Christabel.
Yes, sir.
Yeah, thank you. Thanks to everyone that has contributed. I think my concern is on answering the question itself. I noticed that I think the presenter, because of the subsequent discussion on the disease, didn't really go to town enough in discussing the answer. Okay, for example, when you're talking about the investigations, everything that the investigations will help you do, there are a lot I expected you to mention, you didn't mention. You know, things like complications like endocarditis. You didn't talk about that. Okay. Then even the prophylaxis, do you give how about endocarditis? Do you give prophylaxis for endocarditis in this patient? Because, for example, in your echocardiography, I expected you to talk about that you might see vegetations and all those kind of things. Then it can also help you determine the valvular abnormality, whether it's a regurgitant or if it's calcification. It can also help you look at other valves, because you know that in rheumatic valvular heart disease, other valves can be affected. Okay, so I expected a more robust discussion during answering the question. Okay, so I don't know, maybe for subsequent people, when you're answering the question, please be more robust. You might not even have time to take the subsequent one full discussion. So please discuss more robustly on the questions even before you now talk about it. Okay, I think that's just what I wanted to say. Thank you.
Thank you, sir.
Oh, thank you. Thank you, sir. Thank you so much. Any more comments from our teachers? That's fine. So, Dr. Ibinabo, thank you so much. Please note all the corrections. Anyone that you need to add to your slides, please kindly do that and send to the group, please, so
Yes,
that our
ma'am.
candidates can go through them quickly. Thank you so much. Once again, we appreciate your effort. Thank you. Dr. Ekele?
All right. Thank you, ma'am.
Okay.
Sorry,
Okay,
Dr. Kene. Sorry, Dr. Kene. Please, I also want to stress, sorry, that issue of bringing pan-systolic murmur into the diagnosis, this is the first time I'm hearing about it. I hope we have cancelled it. It's not necessary to be there.
All right. Thank you, sir.
I'm just asking, I know I'm not a cardiologist, but this I've never heard of that before.
It's not. Thank you, sir. It's not necessary, actually. There's no need to describe the murmur. The valvular disease will already point to the fact that there will be turbulence of flow across the valve. So it is expected. Putting it there doesn't really further define the diagnosis.
In fact, I was even expecting her to talk more about higher grades of murmur, like grade 4, grade 5, that there'll be trills on examination and things. But I don't know if that's part of the question, Sha.
All right, thank you, sir. Okay, Dr. Binabo, thank you so much for the beautiful presentation. Please, can you share? Dr. Ike.
Yes, good morning, Dr. Ekene.
Gifts. Please, can you share your slide?
Okay, can you see my screen?
All right, thank you. I can see it. I can see it. So you have 10 minutes.
Okay.
You have
Good
the floor.
morning, facilitators. Okay, thank you. Good morning, facilitators, teachers, and colleagues. I'll be presenting practice question 7, May 2023. I'm Dr. Ike Gifts. Sorry, sorry. I'm sorry, my slide is not moving. Anyway.
Why don't you log out and log in again?
Okay.
So share your slides again. Is your screen, share your screen. Are you sure it's the screen you shared? I just saw your slide immediately. Dr. Kele, is the third presenter ready? Dr. Gift, you're muted though.
Okay. Sorry.
Okay.
Can you see my screen?
Yes. Can you put it on slideshow?
I don't move again.
Try it. Let's see.
Okay. Okay. Sorry for the delay. So we're presenting question 7. It says a 30-year-old obese lady in the obstetric ward had a CS a week ago.
She was walking to the bathroom this afternoon, and when she fell, and her SpO2 was found to be 92%. Heart rate was 110 beats per minute, respiratory rate 30 cycles per minute, blood pressure was 90/62 millimeters of mercury, chest X-ray was normal. A, what is the most likely diagnosis? B, how would you confirm your diagnosis? C, what other investigations would you do, and state the reason for each investigation? D, state 3 scoring systems that can predict your likely diagnosis. Use the scores to risk stratify the patient. Then E, how would you treat this patient? They wanted many different treatment options. So what's the most likely diagnosis? The most likely diagnosis is acute pulmonary embolism. How would you confirm your diagnosis? I'll confirm diagnosis by doing a computed tomography, pulmonary angiography. So what other investigations would you do, and state the reasons for each investigation? I want to do an ECG for this patient, which may be normal. In 40% of cases, I might find sinus tachycardia. There might also be signs of right ventricular strain, where I'll see T-wave inversion in leads V1 to V4, right bundle branch block, which might be complete or incomplete. I'm also see the classical S1, Q3, and T3 pattern, and there might also be atrial arrhythmias, most frequently atrial fibrillation. Another investigation I want to do is a transthoracic echocardiography, which is usually abnormal. There's usually right ventricular abnormality in 25% of patients. The echocardiography will help me identify right ventricular overload and also help exclude other possible differentials. I might also see the 60/60 sign on echocardiography, which is pulmonary injection acceleration time of less than 60 milliseconds with peak systolic tricuspid valve gradient of less than 60 millimeters of mercury. I can also see the McConnell sign on echo, which is regional right ventricular dysfunction with normal apical wall motion despite free wall hypokinesia. The McConnell, it's important to note that the McConnell sign is a distinct echo finding in patients with acute pulmonary embolism. So I also want to do a ventilation perfusion scan where I'll see a ventilation and perfusion mismatch. I also want to do a compression ultrasonography for these patients where I might see clots in the deep vein. I also want to do arterial, and I also want to do arterial blood gases where I see hypocapnia and also hypoxemia. Also a D-dimer, I want to do a D-dimer for these patients, which has a good negative predictive value, and also bearing in mind other causes of elevated D-dimer. So other investigations, flow counts, which will show leukocytosis and increased ESR. I want to do an electron urine creatinine, where serum creatinine will help me estimate the pulmonary filtration rate and help determine the safety of administering contrast to these patients, and also affect my choice of oral anticoagulants. Then brain natriuretic peptide 2 will also be elevated, and also troponins 2 would also be elevated. So use the scores. Okay, how do you score this patient? Use the scores to stratify the patient. So I want to use the Wells and revised Wells score, and also the Geneva and revised Geneva score, and also the pulmonary embolism rule-out score. For the revised Wells score, the index patient have a score of 6, which places the patient at intermediate probability at the 3-level scoring stage, while for the 2-level scoring, the patient is placed at a PE likely. For the revised Geneva score, the patient has a score of 7, which is also intermediate probability. For the pulmonary embolism rule-out score, the patient has a score of 3 out of 8. So this is just the Wells score. The patient has heart rate greater than 101.5, then surgery and mobilization within the past 4 weeks 1.5, then alternative diagnosis less likely than P, so giving the patient a score of 6. And for the reversed Geneva score, the patient had surgery within 1 month, so that's a score of 2. Then also heart rate greater than 95 beats per minute, that's 5, giving the patient a score of 7. So for pulmonary embolism rule-out score, the patient had a score of 3, pulse greater than 100, SpO2 less than 94, and recent surgery. And the pulmonary rule-out score is positive if the patient has 1 out of the 8 criteria. So how would you manage this patient? I want to manage this patient using a multidisciplinary approach. I want to involve the cardiologist, pulmonologist, and the other members of the team. I want to determine the presence or absence of hemodynamic stability or instability based on clinical evaluation. I also want to determine the severity of pulmonary embolism, It gives an index of early mortality, and patients will be classified based on high risk, intermediate risk, or low risk. I also want to determine to determine the severity of pulmonary embolism. It's based on these criteria to determine the pulmonary embolism severity index, the presence of right ventricular dysfunction on transthoracic echo, CTPA, and also elevated troponin. So this is what with my patient, the index patient is placed on early mortality risk and intermediate risk because the patient is hemodynamically stable and also has an SPESI score of greater than 2. That's a pulmonary embolism severity, simplified pulmonary embolism severity score of 2. So which places the patient at intermediate risk for early mortality. So this is the pulmonary embolism and severity score, pulse rate of 1, systolic blood pressure of less than 100. So giving the patient a score of 2. So management of this patient, I want to initiate anticoagulation for this patient. The initiation of anticoagulation, there are several options, either parenteral anticoagulant and an oral anticoagulant. Okay, for this patient, I want to commence a parenteral anticoagulant using the low molecular weight heparin at a dose of 1 milligram per kg 12 hourly. Or I could use the fondasparinos, which is the dose is given subcutaneous weight based. I also can commence, if I'm using the parenteral anticoagulant, I want to give that for 5 days and subsequently convert this patient to oral anticoagulants. So if I commence, I could also use the oral anticoagulants without the parenteral anticoagulant, where I might use any of the either apixaban, rivaroxaban, depending. Then I also can use the vitamin K antagonist for this patient. Using the vitamin K antagonist, I want to also give a parenteral anticoagulant with the vitamin K antagonist for at least 5 days, and until until I achieve an INR of 2.5 for at least, and that will be sustained for at least 24 to 48 hours before I discontinue the parenteral anticoagulant. So this is just to show the doses of the different anticoagulants that could be used. So this my patients can deteriorate even while on my anticoagulation and therapy. So if my patient deteriorates, I want to do a rescue thrombolysis for this patient if there are no contraindications to thrombolysis. So if there are contraindications to thrombolysis, I want to do a surgical embolectomy for this patient or a percutaneous catheter-directed treatment for this patient. So how would you, still on the management, I put suspect patients with high risk, but patients in intermediate risk, since they said they wanted different options. So suspected high risk patients, you want to give your unfractionated heparin at 8 international units per kg. IV, you would have done your ECG and echo to exclude other causes. If the patient SpO2 is less than 90, you want to give your patient intranasal oxygen. Then the patient might also have concomitant hypovolemia. So you might want to give 200 to 500 ml of IV fluid, normal saline. Also might want to give, I also want to give ionotrops. So if necessary, I want to intubate and mechanically ventilate this patient. So if my patient is stable after my initial therapy, and I now want to go ahead to do the CTPA to confirm PE, pulmonary embolism. But if the patient is not stable, I will also want to consider an extracorporeal membrane oxygenation for this patient. Then go ahead to do, if PE is confirmed, I'll go ahead to do my perfusion therapy. That's the thrombolytic therapy. Then if there are contraindications, I will do surgical embolectomy or catheter embolectomy. So this is just trying to show the dose of the thrombolytic agent I want to use is the one I want to use is the recombinant tissue type plasminogen activator at a dose of 100 milligram over 2 hours for this patient. So for chronic treatment, this is trying to I'm trying to look for the risk of recurrence over a long-term period for this my patient. My patient falls under the low risk, so I want to treat this patient for 3 months following the guideline. So I want to
you have 1 moment.
Okay.
You have 1 more minute.
Okay, I want to do a brief orientation on pulmonary embolism. Pulmonary embolism, blockage of one of pulmonary arteries by any material movement, right? It could be a thrombus, air, or gas. So it's important to note that most PE-related deaths do not appear due to failure of therapy, but more to failure of prevention and early recognition. Then 2 of 3 patients die from PE within 2 hours of presentation. So the etiology of PE, we have 3 predisposing factors: endothelial injury, stasis, and turbulence, and stiffness or turbulence of blood flow and blood hypercoagulability. So this is just showing endothelial injury, venous stasis, and hypercoagulable states. For the pathophysiology, acute PE interferes with both circulation and gas exchange. So right ventricular failure due to acute pressure overload is considered the primary cause of death in patients with severe PE. So you have increased right ventricular wall tension, there's increased right ventricular oxygen demand, decreased right ventricular contractility, which will eventually lead to obstructive shock and death. This is also explaining the pathophysiology. Then for predisposing factors are divided into strong risk factors, moderate risk factors, and weak risk factors for PE. For the clinical presentation, the patient's presentation of PE vary from sudden onset to gradual progressive dyspnea. For patients who have pre-existing heart failure or pulmonary disease, worsening dyspnea might be the only symptom indicative of pulmonary embolism. So we need to have a high index of suspicion. So other clinical signs and symptoms, tachycardia, rales, lower extremity edema. Then there might also be features of deep venous thrombosis. So for where there's no obvious cause of the embolic disease, you might want to screen, do a hypercoagulation and workup, looking for antithrombin 3 deficiency, lupus anticoagulants, and other investigations. So for diagnosis of PE, could be chest X-ray, ventilation, perfusion, scan, CTPA, ultrasound, ECG, echo, cardiography. So chest X-ray is usually abnormal. So these are the different signs you could see on chest X-ray. We talked about ECG already. So echo, the ventilation, and perfusion, and it's recommended that you reject the diagnosis of PE if the perfusion lung scan is normal. There are some indications where you want to do a perfusion, ventilation perfusion scan, outpatients with low clinical probability in young patients, pregnant patients, in patients who have history of contrast medium induced anaphylaxis, and patients with severe renal failure in CTPA. Then for D-dimer, you want to use, if patients have any of these three symptoms, you have the clinical signs of DVT, hemolysis, PE most likely. If they have any of these, you want to use a threshold of 500 nanogram per ml. But if they have none of this, use a threshold of 1000 nanogram per ml. So this is just trying to look at treatment, place treatment of PE based on hemodynamic instability and hemodynamic instability. For if the patient is hemodynamically unstable, the first thing you want to do is do a TTE, looking for right ventricular dysfunction. If none is present, you look for other causes of shock. If it's present and if CTPA is immediately available and feasible, you want to go ahead to do that to confirm your diagnosis. If not, you just go ahead and treat. But for patients who are hemodynamically stable, you want to use your probability scoring into high clinical probability, low or intermediate. Then if it's low intermediate or PE unlikely, then you do your D-dimer before you go ahead. If it's positive, you now do your CTPA. But if it's high clinical probability or PE likely, you go ahead straight to do your CT and PA. So there's also room for supportive management in patients with PE, where you want to give intranasal oxygen if the patient's SpO2 is less than 90. Talked about giving an IV fluid normal saline. Okay, this is just the anticoagulation therapy. So it's important. So for patients, you can determine whether the thrombolysis is successful, and it's just by persistent clinical instability and unchanged right ventricular dysfunction and echocardiography after 36 hours of your thrombolytic therapy. And the patient has the greatest benefit when the thrombolytic therapy is given within 48 hours. These are some contraindications to anticoagulation and therapy. For your catheter-directed therapy, there's fragmentation of the clots, and also altarplase is also given, but more at a reduced dose, 20 to 25 milligram instead of 100 milligram IV. For patients with low risk, you want to look for, is there clinical signs of PE severity or serious comorbidities, or is there right ventricular dysfunction on TTE or CTPA? If none of this is present, you classify your patient as low risk. Then look for other reasons for hospitalization. Is there family and social support? Is there early access to medical care? If yes, all these are true, you want to discharge your patient home. So they must meet these three criteria before you can discharge them. Then for post-embolic prophylaxis, you want to... sorry. Okay, so for follow-up, you want to give your anticoagulant, follow the patient for 3 to 6 months, looking for dyspnea or functional limitation. If the dyspnea or functional limitation is present, you want to do a TTE to rule out pulmonary hypertension and all that. So for pregnancy, sorry, so in conclusion, pulmonary embolism is the result of clot in the pulmonary artery or one of its branches. If untreated, PA can result in death. The goals of initial treatment include clot resolution, long-term and extended treatment, but aim to decrease the risk of reoccurrence. These are my references. Thank you.
Wow, thank you so much, Dr. Gift. I know pulmonary embolism is a very big topic. Okay, so let me just take some comments on the chat. Say thank you, Chief. Please, is contrast enhanced CT safe in the postpartum period? Hello, Dr. Gift.
Yes, okay. So what I saw is that contrast, they said during pregnancy, but postpartum period, you want to do a VQ scan for the patient if the chest X-ray is normal. But you can do your CTPA in pregnancy because it has just reduced the dose of radiation.
I don't know. I think CT can do CTPA postpartum, except the patient has renal impairment. Anyway, maybe we'll get more comments on that. Dr. Falabi says, thank you for the presentation. I think the diagnosis, okay, no, that's been taken care of. So the diagnosis is acute pulmonary embolism. Okay, let me just make one or two comments. For that criteria talking about for the D-dimer, it's called the YES criteria. So if the patient has just one positive of the three, can we move in the slides back to the question? Then you use D-dimer level greater than 500 as positive for pulmonary embolism. But if the patient has none of the YES criteria present, then you use 1,000. And there's also an age-adjusted D-dimer where you, for those greater than 50 years. So for instance, the patient is 60, you say 60 times the D-dimer level to get the 60, that's 10 times the age, 10 times the age to get the normal value for that patient. So if patient is 60 years, so 10 times 60. So the patient's cutoff for D-dimer will be 600 nanogram per mil. Then for this particular patient, since you were able to do a CTP, I don't think it's necessary to do all because CTP is actually the gold standard for now. If you're able to do a CTP because the patient is kind of like the well score was greater than 4, there's no need to do VQ scanning and D-dimer in the same patients. That's my thoughts. And then patient is hemodynamically stable, like the systolic blood pressure is 90. So I think for those patients, anticoagulation will be fine. Then for the high risk, intermediate risk, and low risk, I think if the patient is in high risk, you can do thrombolysis within 48 hours and even up to 14 days. If the patient is in intermediate risk, can do that, the surgical embolectomy, and then if the patient is low risk, anticoagulation will be fine. Okay, so those are the comments I can remember for now. I don't know if we have more. Okay, there are some hands up. Dr. Okorafo, please go ahead.
Good morning, my teachers and respected colleagues. I want to thank the presenter for a very beautiful presentation. However, I want to slightly have a different view for the management of this patient. And of course, I'll welcome corrections. This patient, I think this patient should be managed as one that has massive pulmonary embolism. This patient actually fell down, the SpO2 is down, and I will assume I'll manage this patient as being hemodynamically unstable. The blood pressure is already 90/62. So I don't know if we want to wait until it is less than 90. That being said, the first thing to do for this patient is to quickly well score. If we quickly well score, and then we start heparin, not subcut enoxaparin, because we need something that will act as fast as possible. So we'll give a loading dose of heparin at 80 international units per kg, or between 5,000 to 10,000 international units starts. And then after that, we'll now go ahead to now continue this patient on 1,300 units per hour of heparin, or you can do 18 units per kg per hour of heparin. Now, while you're doing this, you will have to monitor the APTT of this patient every 6 hours, and then hope to discontinue this heparin if the upper limit of, if the APTTK is 2 times upper limit of normal, 2 times more than the upper limit of normal. So you now discontinue the heparin and then switch back to subcutaneous Clexane. Okay. Now, there is no need in this patient to go and start running around for CTPA because time is of the essence. This is a massive pulmonary embolism. So while you've commenced these medications, like I've mentioned, you only need 2 things. Is either you do a D-dimer, is that you do Doppler of the lower limbs to find a clot, or you do your echocardiography for this patient. Either of them, if you find anything suggestive of pulmonary embolism in either of them, I mean, if you find a clot or if you find features on the echo that suggest that this patient has pulmonary embolism, that is the diagnosis. So you don't need to go and start doing CTPA for this patient. Now, having nailed the diagnosis at this point, you now reassess your patient. If your patient is continually deteriorating despite giving your heparin, then you can now consider giving this patient thrombolytics to lyse the clots. However, if the patient is not deteriorating or even improving, then you can now continue your heparin until you've achieved an APTT that is more than 2 times the upper limit of normal. And then you now switch to subcutaneous Clexane and then continue to manage the patient. So that is the view I hold for managing this patient, because I think this is an acute pulmonary embolism, and I suspect, or I believe that it will be a massive PE. So the way to manage for a patient that doesn't have a massive pulmonary embolism is slightly different from how you manage a patient that is probably stable and has no dangers, imminent danger. So that's my view, but I welcome contributions and corrections. Thank you very much. By the way, thank you for the presentation.
Yeah, thank you. Okay. Sorry, the patient. Yes, the patient is hemodynamically stable. The definition of the hemodynamic instability is systolic blood pressure of less than 90, or a 40 millimeter drop in the systolic blood pressure from the baseline. That's what the guideline says. So it's 96. So when the blood pressure is 90, systolic blood pressure is above 90, the patient is hemodynamically stable. And for the unfractionated heparin you talked about, the 80 IU per kg is used for patients who are high-risk patients who you are going to thrombolyze, not for patients who are hemodynamically stable. Initially, they could use unfractionated heparin for both hemodynamically unstable and unstable patients. But now the guideline reserves that you should reserve the unfractionated heparin for patients who are hemodynamically unstable and who you are also going to thrombolyze. So this patient is not, so you manage this patient at high risk, but you bear in mind that the patient might deteriorate even while on your anticoagulation. That's when you now do your rescue thrombolysis. And they said they asked for several options for treatment. That's why I put the low molecular weight heparin, the Fondaspirin. They said they wanted many different options to treatment.
All right, thank you so much.
Sorry, so in essence, the blood pressure has to be below 90/60 before we consider the other option. That's what you're saying.
No, okay. You have to, first of all, you have to classify whether your patient is hemodynamically stable or not. That will determine your treatment. You understand? So if your blood pressure is greater than, we don't have. Okay.
Excuse me, I want to chip in here. During your presentation, you were saying the patient is intermediate risk, and in another scenario, you were saying the patient is low risk. So what is your stand regarding this patient, so that we know what to take?
Sorry, Chief, I didn't get the question.
While you were doing your presentation, you were saying the patient is intermediate risk, and again, you were also saying the patient is low risk. So what is the risk stratification of this patient?
Okay. The patient
did
is
you classify?
intermediate. The patient is intermediate risk. Where I talked about low risk is risk of recurrence. That's where I classified the patient as low risk. It's risk of recurrence of PE. But this patient is intermediate risk.
No, regarding the treatment, the question says, how will you use the score to risk stratify the patient, not risk of recurrence. The question is asking risk stratification as per treatment.
Yes, this patient is intermediate risk.
Okay, so if she's intermediate risk, then your treatment will be what? Because during the discussion, we are going very fast. So maybe that's why the confusion is coming up.
Okay, for
so
intermediate.
If she's intermediate risk, how will you treat the patient? I think that's the confusion why Dr. Maduka is bringing up his own line of management.
Okay, for patients who are hemodynamically unstable and intermediate risk, what you want to do is use your parenteral anticoagulant. You can use a low molecular weight heparin for the patient at a dose of 1 milligram per kg 12 hourly or 1.5 milligram per kg a day. You can use that for 5 days, then subsequently you can switch to your oral non-vitamin K antagonist anticoagulant subsequently. But you keep monitoring the patient because your patient might deteriorate even while on this your anticoagulation therapy. If your patient now deteriorates, you now go ahead to do a rescue thrombolysis for the patient, where you want to use your recombinant tissue plasminogen activator. You give that to your patient. But they ask for different treatment options. That's why I brought up that you can also use fondospirinos. You can also use a vitamin K antagonist, where you want to also give your parenteral anticoagulant for at least 5 days, and you also monitor the patient's INR until it's greater than 2.5, and that is maintained for at least 24 to 48 hours before you stop a parenteral anticoagulant and continue with your vitamin K antagonist. That's for patients who you cannot place on NOAC. So they ask for different options. That's why I was bringing up all the different options you could use to treat.
Okay,
thank you
then Dr. Ekele, please, there are pulmonologists raising hands. Let them give us their own opinions.
Okay, that's what I was going to ask Christabel. The time is up. Can we still go ahead? Okay, Doctor.
Please go ahead. Just
Dr.
go ahead.
Okay, Dr. Timmy, please go ahead.
All right, good morning once again. Thank you for the presentation. So I think first of all, we need to look at the question. So that history of fall, I know it's a recall. I would want to know, did she fall because she lost consciousness like a syncope, or she slipped and fell? Because if she fell because it was maybe a syncope like instability, if is that she suddenly lost consciousness, then she fell, maybe she was resuscitated, and then these are her vitals. But if she just she didn't lose consciousness, she slipped and she fell, then going by the recommendation, then she's not hemodynamically unstable based on these parameters, then we will now use the PE severity index to stratify into whether she's intermediate risk or low risk. And looking at these values, she's intermediate risk. So for the intermediate risk, we are supposed to further classify the intermediate risk into intermediate high risk or intermediate low risk using either troponin or the bedside echo with the parameters that you talked about. So if any one of them, whether troponin is high or the bedside echo is showing features of right ventricular dysfunction, not just the PASP now, those other parameters you talked about, if any one of them is present, then you should actually treat with unfractionated heparin. And if it is available in the facility, you can actually do a catheter-directed thrombolysis if the patient is intermediate high risk. But for the intermediate low risk, you can do the other treatment, the low molecular weight from the Parinox, whichever. So I think that is the bone of contention here. So the scenario painted, that fall because you know that hemodynamic instability is two things, either hypotension or cardiac arrest, and the person was resuscitated. That is still a hemodynamically unstable person in the setting of PE. So whether the patient has hypotension or the patient had a cardiac arrest and was resuscitated, that is high risk and you should do systemic thrombolysis. But if neither of those two parameters are present, then using your PE severity index and a simplified one that you did to make it easy in terms of exam. So the simplified PE severity index, there's a simple algorithm you can use to be able to remember. So 80, 90, 100, 110, then C is letter C. So there are three components of C. 80 is age greater than 80, 90 is SpO2 less than 90, then 100 is systolic blood pressure less than 100, then 110 is heart rate less than 110. Then the three components of the C is if the patient has CCF, if the patient has COPD, or if the patient has a cancer. So if any one of these parameters is present, then the patient has a the patient is high risk under intermediate. So you only use the PE severity index when you have established that the patient does not fall into the high risk based on hemodynamic instability. So you are using the PE severity index to know if the patient is intermediate risk or low risk. And then, heart rate greater than 110. So if any one of those simplified parameters is present, then the patient is intermediate risk. Then you now further stratify using your troponin or your bedside echo. And then based on the other things you talked about. So, okay, let me allow other people to talk, but that's my own contribution. Thank you.
Thank you so much, Dr. Temi. Dr. Paul, go ahead, please.
Okay, thank you very much. Thank you very much, Dr. Gibbs, for the presentation. Just initially, when you are talking about the PE rule-out criteria, so normally there's the clinical decision support system that can be used for pulmonary embolism to help structure the approach to investigating this patient, because not all patients you want to be exposed to CTPA for them to do CTPA. So you have to do some tests decision making to exclude those that will not necessarily need the investigation or do PE. So there's this unstructured clinical approach whereby in the clinician's view, does the clinician think that this patient in front of him or her has PE or not? So if there's less than 15% probability that this patient will have PE from the clinician's opinion or point of view, the patient will not be exposed to do a PE rule-out criteria. So you do that. But if there's a high probability, like more than 15%, that there's a high index of suspicion that this patient has PE, you go on to do the structured clinical assessment, which is the Geneva and the Wells criteria. So now the PE rule-out criteria, you don't use it for inpatients. You usually would use it for outpatient basis. So maybe you're seeing the patient in the clinic. You'd now have there are like 8 items, 8 criteria that if the patient fulfills all 8 criteria, you've excluded PE. So those items that you posted, if the patient fulfill all 8 criteria, the patient PE is excluded. You don't need to go further to do Wells or Geneva. But if the patient has 1 or more criteria, if he fails to meet 1 or more criteria, then you now go on to the structured, which is the Wells and the Geneva and the years item. So that's what I wanted to point out. Then Dr. Temitope has said all about the risk stratification is very important. So if it's hemodynamically stable or unstable. So if it's hemodynamically unstable, you know that it's perfusion, that you need perfusion for immediate reperfusion therapy using the intravenous the arteplase or tenecteplase after excluding any if there's any contraindication, you go to that. So if the patient is stable, you know that it's perfusion, that you need perfusion for immediate reperfusion therapy using the intravenous the arteplase or tenecteplase after excluding any if there's any contraindication, you go to that. So if the patient is stable, if the patient is Then you will not have to do other tests like ECG, troponins. If they are elevated or the range, it puts that patient in intermediate risk. Then you give low molecular weight heparin. But if you've done all this, the patient is hemodynamically stable, there's no right ventricular strain, the cardiac biomarkers are okay, everything is okay, then you can treat with DOAC. You understand? So this is just the risk stratification based on the treatment. Then for that PESI score, the PE severity index, is usually used to predict 30-day mortality. So because there are prognosis, there are items in your investigations, like maybe if the patient comes in hemodynamically unstable, if the patient has a right ventricular dysfunction, if the patient has a DVT with the PE, all these are poor prognostic factors. So the PESI helps to prognosticate for a 30-day mortality risk assessment scores. So there are different items that you can use to stratify this patient based on the risk of mortality over a 30-day period. So I think that's what I wanted to contribute. Thank you.
Thank you so much. Thank you, Dr. Ekele, Dr. Paul, Dr. Timothy, and everyone that contributed. Thank you so much. Thank you. Dr. I think the other comments we have to post it on the WhatsApp group. Thank you. Dr. Gift, this was such an elaborate. See how you stimulated this active discussion. I appreciate you. Thank you so much. Thank you. It's 16 minutes past 8. I appreciate everyone for coming, our teachers, our candidates. Thank you all for coming. And the presenters, they both did wonderfully well today. Please